Welcome to another case review. We have just returned from Tijuana, Mexico yesterday. Today is October 20th of 2024. We've just completed a 4 days intense surgery program with Implant Accelerator at the MINEC facility in Tijuana, Mexico. This is a case that Dr. Hoang from Northern California has completed on the first day. The patient's name is Guadalupe, and it was done together with myself and Dr. Chris Kim, one of our faculty members at Implant Accelerator. This was, of course, after the surgery was done. Happy crew, happy evening, celebrating all the great surgery we did that particular day. So this is a case that Dr. Hoang has treated. This is a case where a lower first molar is missing, and the lower second molar actually happens to be mesially tilted, providing quite a bit of an issue, not the ideal situation. So patient was quite open to the fact that she was okay to remove the tooth and indeed have two implants placed. This is a radiographic view of her situation. Obviously, she's had a number of implants placed in the clinic, and we did decide to remove that second molar and to place two implants in first and second molar sites to the best of our ability. Now, what we need to realize here is not only is the edentulous ridge narrow in terms of bone architecture, but also the fact that there's very small zone of keratinized tissue, and it's going to be a challenging soft tissue situation. So extracting these tooth and how on earth do we manage the soft tissue? So let's take another closer look at this case. Around the bicuspid areas, there seems to be just adequate, just enough keratinized gingiva. You can see by the bleeding spot where the blood has pooled at the mucogingival junction, and equally so you'll see that on the facial aspect of the molar, where it's a clear demarcation between mucosal tissue and keratinized tissue. So we know that keratinized tissue is quite in deficiency in all the areas. But if you pay attention to the distal of the second molar, there seems to be a good amount. And if you pay very much of attention on the very center of the edentulous ridge, there does seem to be small but somewhat meaningful amount of keratinized tissue that is also quite thick. So here's a graphic rendition of where the two implants ought to be. One right in the edentulous ridge, and the second one in the second molar side. Because of the tooth's unusual position, it was going to be somewhere in that mesial root position of that existing molar. So if those two implants were going to be exactly in that position, we do want adequate keratinized tissue on the whole of the facial aspect, and we know that 2 millimeters seems to be the consensus as to how much width of keratinized tissue is almost a requirement. So let's inspect the second molar again. There is that triangular area of keratinized zone. And the incision here is the distal oblique incision starting from the distal lingual line angle. This is strategic to not only avoid possible lingual nerve in that lingual aspect of that molar, but also to try to create this triangular tissue. And the next slide will be quite evident as to what we're trying to do. As you can see, that incision in the distal as well as the crestal on the edentulous space is already made, and you are going to have a guess as to what we're going to do here. Another very important point quickly. Do we take the tooth out or do we flap first? This is a simple and very, very simple debate in my opinion, but we see this in the clinics all the time. Every time we're doing an extraction immediate case, there seems to be a predominance of people just jumping to put elevator or pair of forceps to remove the tooth. Many times it's tempting because the tooth might be loose, or that's the first thing you can do with confidence. But why would you go in and start to destroy the gingival margin and the pristine soft tissue that we really require? So in my opinion, flap and incision design just comes first. So in this case, we've already done the flap, elevation, incision design, all of that, and then the tooth comes out. In this case, a slight challenge because of the root length and the curvature, but it really didn't prove to be that much of an issue. But as a result of that, we have very, very clean, crisp edges of the flap that we're going to be manipulating, as you see right here. So now that we have that distal triangular tissue that was carefully preserved and separated, and of course freed up by some periosteal release, then what we can do is advance the tip forward. And by doing so, we can close up that V, the V that used to be part of the facial gingival margin or the architecture, and then suture that together. Furthermore, we are going to go slightly forward, and where the very narrow zone of keratinized tissue was at the edentulous ridge, at the previous edentulous ridge, we can somehow increase the thickness by bringing the mesial aspect of the second molar gingiva towards the straight facial aspect of the future first molar site. So as you can see, this is a straightforward, simple, yet quite nice, innovative way to increase the zone of keratinized tissue immediately facial to the future implant, where we will truly need that zone of keratinized tissue and thick non-mucosal, non-movable tissue to our advantage. So here is the suture work, and as a result of that, we have now gained a good, decent zone of keratinized tissue, thick tissue, as well as the mucosal tissue away from the gingival margin, and quite deep, reasonable vestibule to be formed. Let's review this really quickly because it's not that easy to understand. So I've just done a quick graphics here. The bright pink represents keratinized tissue, and darker pink the mucosal tissue, as you clearly see it outlined here. Here, the two gray dots represent where the future implants ought to be, and if somebody were to, you wouldn't, but if somebody were to do flapless procedure, this would be a disaster waiting to happen because especially that first implant, the first molar implant, there will be absolutely no keratinized tissue under these circumstances. So we raise the flap, did the incision design, then we remove the tooth, and that leaves us this movable tissue. Now that the flap is raised, and now we can manipulate the flap. So this is pretty much a anterior pedicle. We're just rotating the pedicle towards the anterior side. So you can call it a number of different things, but you can call this rotational pedicle or a simple coronal rather anterior advancement, whichever way you call it. Here is that curvature of the tissue going forward. And as we had seen previously, the suturing simply brings that edges together, making the V, or what used to be the facial gingival margin, disappear in expense. We bring in more keratinized tissue, as this graphics describe with the suturing. Then, once we loosen up the tissue at the mucosal junction and the first molar edentulous site, then we forward that, remove that tissue, bring the thickest portion forward like this, create an artificial V, and then use a suture to bring that together, and therefore we create a much more abundant zone of keratinized tissue. And of course, this is not possible unless we do generously release the periosteum. And in the clinics, we've used a variety of different methods. The three common method that is used to elevate or advance periosteal tissue, or flap rather, and that is to use a pair of scissors, blunt dissection, a blade, 15C typically, being extremely carefully at the periosteum level, or one of my favorite methods that I have shown everybody in the clinic at least once, and that is to use a serrated spoon, the good old JK instrument, to use a lifting maneuver that identifies the tough fibers that resist and to clearly identify and sever, tear, extend these fibers for tissue movement. And again, this is the clinical view on the facial aspect where we have now artificially thickened the tissue. This is a lingual view, not the best photograph, but this is a lingual view. But on this view, you can see that on the facial aspect, we have abundance of thick keratinized tissue. So our flap design clearly has met the objective of improving and or gaining a lot more thickness of keratinized tissue. So the implant placement and the drilling process, the osteotomy process, is in place here. We are using the guide pin as well as drill to clearly assess the implant position, the three-dimensional ideal positioning of the implant. This is actually quite a good placement. I'm going to be very critical. We are looking to place a molar. So in order to place a molar, the set distance, we want the tooth dimension to be somewhere between 10 to 12 millimeters mesiodistally. In other words, the center of this implant osteotomy should be 5 or 6 millimeters from the distal line angle of the existing tooth. Another way to do it graphically, and we have the luxury after the case is completed, is to simply cut and paste outline of the adjacent bicuspid. According to this little exercise, the future implant here will be exactly the size of a bicuspid, which is not the ideal. So it would have been better if we would have visualized this and perhaps put that implant slightly more posteriorly. In this situation, maybe 1.5 millimeters or even 2 full millimeters, looking somewhat like this. So looking at this from the occlusal, if we put in an imaginary molar, then we will all agree that the implant position could have been pushed distally by roughly 1 millimeter, 1.5 millimeters or so. I'm being super critical so that we can take this as a learning opportunity and improve this very technique in the future. One of the nice features when we place multiple implants is the protocol should be you place the first one, in this case the first molar, relative to the existing bicuspid adjacent tooth, and then this silver structure is called the pathfinder. As you can see on the top, the occlusal view shows a hex hole. In other words, this is designed so that a screwdriver can be used to insert this, and as the screw threads indicating at the bottom, it screws in so it securely stays into the implant, and this gives us a visual cue as well as dimensions, and that becomes a method to make the second implant placement to be parallel to the first one. So this is the result of the first and the second implant placement, slightly off, not perfectly perpendicular, but I think this is quite an acceptable result. And as we have discussed earlier on, the second molar implant is slightly forward of the existing tooth position. In other words, the socket is slightly forward of that. Now that the implants have been secured and confirmed, we are going to be grafting. I think the bone was quite sufficient, but this is really what we call the contour grafting. This is literally an insurance policy to have that extra body volume of bone and soft tissue on the facial aspect, where we have a slight narrowing and slant of the bony architecture. Both of these implants were placed soundly into the host bone. So again, this is literally an extra amount of bone tissue for the long run. Now that the bone is placed and CGF using the poncho technique has been placed in the right spot, now it's a matter of completing the suturing technique to keep things into place. What you see in the screen, on the very top of the screen, the white structure, I want you to pay attention to that. What is that? That is actually the 2x2, the cotton gauze that is blocking the floor of the mouth from communicating with this surgical wound. This surgical wound is now the recipient site of sticky bone allograft. We made sticky bone using allograft and the autologous fibrin glue. Now, this is a quick Google review. When you ask Google enzymes in saliva, it spits out at least 3 known enzymes: amylases, lysozymes, and lipase. These names indicate that these are important enzymes that break down things, mainly fat and proteins. And we know that's the job of the saliva because it breaks down food as a part of the digestive system. So why on earth would you want saliva to go into the graft site? It is a huge mistake, but we all tend to make this mistake constantly. So isolation is extremely important to make sure salivary enzymes are not being introduced into the wound inadvertently, nor is bacteria. So, of course, with any surgery, common sense dictates that we scale and root plane this area before and during the operation. And once you get to this particular site, as step of the procedure, we will irrigate and thoroughly with saline, sterile saline, and then isolate the area with some cotton and a important instrument such as a dental mirror. You can actually see part of the dental mirror being held right next to it to not allow any excessive saliva creeping into the wound. I really can't say this very much, but this is so important. We see our colleagues making this simple but critical mistake all the time. So now that the suturing was done, this is the aftermath. I like to use chromic gut. This one is a 4-0 chromic gut, and if you ask me what kind of configuration that is simply a configuration to hold everything together. Number one, graft containment. We do not want the graft to spill out or get contaminated, and you can see abundance of CGF, concentrated growth factors, especially you see part of the poncho technique on that anterior implant. The posterior implant had a healing abutment that was not as tall. We had limitations of a variety of inventory, so that was not the best situation. But it is immediately under there, and I am confident this is a type of case that in the very near future, the second healing abutment will automatically appear as the tissue tightens up. So graphically, this is the rough zone of keratinized tissue that we have created, and I feel confident that we may not need to graft any more soft tissue in this case due to this innovative flap manipulation to try to increase the zone of keratinized tissue. Here is a panoramic view, immediate post-operative. As you can see, the healing abutments are tall. The second one, the second molar healing abutment, is not as tall, and I wish it was. This is the pre-op view showing where the tooth was still intact, and this is a side-by-side view. We took a CVCT, and here is the rendition, the first implant. As you can see, the implant is soundly in bone. However, there's a huge volume of bone that we've grafted. You see it to the left of the screen, which represents the facial aspect, and that is more than adequate. And even if we lose 50% or more of the bone, this will give us an ample amount of new healthy bone. And this is a second molar site where we see equally great amount of bone. And again, whether we lose some of that bone or we're not, even in the dire situation where not all of that implant, the bone solidifies, we surely have enough bone structure to be able to support this implant now and in the future. Finally, this is a video of the area. I had tried my best to hold my iPhone while we were manipulating the chest so that we can get a good visual of the relative to occlusion as well as the surrounding structures. It's beautiful work done by Dr. Chris Kim and Dr. Kim Hoang from Northern California. Dr. Hoang is right there in that front, that lady right here in the front of that pack. This time we had about 9 amazing doctors from all over Northern America, and we surely had an amazing time. So thank you to all the participants, thank you to all the support team, and hopefully we'll see you sometime, and we'll be able to discuss more exciting cases very soon. Thank you.